Can everyone see my screen? Great, I did it correctly. Okay, just one more minute, I think. And Carlie, thanks for letting folks in. Okay, let us begin our program today. Hello, everyone, and welcome. I'm Lori Marie Peixoto, and I'm the Executive Director of the Mental Health Association of Rhode Island. I'm so happy that you could join us today. We have a really terrific and interesting program for you. First, just a few housekeeping tips. If you have a question as we go along in our discussion, please type it into the Q&A box. And I will try to read your questions as it fits into the conversation when there's a natural pause. And I will also ask for questions at the end of our discussion. So if something hasn't been answered and you would like to ask one of the panelists, you'll have a shot at the end of the discussion as well. Second, just to let you know, this conversation is being recorded and we will post this video on the Mental Health Association's YouTube page. You can also share the link and post it on your own social media pages or on your websites. Feel free to share it in your newsletters or in emails to your friends and family. The Mental Health Association, for those of you who are not familiar with us, we are a small nonprofit consumer advocacy organization. We're based in Providence, Rhode Island. We've been around since 1916, and we focus on systems change. We focus on improving the system of the mental health care in Rhode Island and increasing access to treatment for all Rhode Islanders through advocacy, policy development, education, and research. I'd like to give a really big thank you to Rhode Island College. Rhode Island College is our theme sponsor for May's Mental Health Month 2021. To see a special video message that was recorded by Rhode Island College's Clinical Mental Health Counseling Master's Program, you can go to our website, which is listed here, MHARI.org/MIMHM for May is Mental Health Month. It's on our homepage. The clinicians at this program recorded a really heartfelt message to thank all of the frontline behavioral health care workers who served Rhode Island throughout the pandemic with bravery and compassion in a time where we had a lot of uncertainty about this new disease that we were grappling with. So a really big thank you to our frontline workers and also to Rhode Island College. So please check out their video. Also want to give a shout out to another sponsor and longtime friend of the organization, Butler Hospital, located right here in Providence. Thank you so much, Butler. So now let me stop sharing my screen and get on with our discussion. Today's program is entitled The Intersection of Race, Culture, and Mental Health. This workshop is part of our May is Mental Health Month lineup of speaking events. We have a full calendar, which you can find on our website's homepage. This year's theme for May is Mental Health Month 2021, our theme is Equity Requires Action. And this is a call to action. It's meant to inspire us all to collectively work for equality in Rhode Island's behavioral health care system, to end disparities, and to engage underserved communities. Today, we have a talented and knowledgeable panel of local mental health care providers and scholars to help us explore how culture and race impact one's mental illness experience. We will also discuss the cultural and racial disparities that persist within the mental health care system today and the steps that we might take to ameliorate them. We're so lucky to have Dr. Ernestine Jennings, Sandra Victorino, and Yumin Tan. Let me tell you a little bit about each of them. Dr. Jennings is a clinical psychologist at the Miriam Hospital and the Alpert Medical School of Brown University. She conducts research and provides care in the community, and she's also a member of the Mental Health Association's Board of Directors. Sandra Victorino is the Director of Workforce Development, Diversity, Inclusion, and Community Relations at Care New England, and she's the co-founder of the Latino Mental Health Network of Rhode Island. She's a board member at the Women's Fund of Rhode Island and the Mental Health Association of Rhode Island. And she's on the Behavioral Health Advisory Board at Clinic Esperanza, which is a free clinic for the uninsured, Luna U, a free clinic on maternal well-being, and the Health Insurance Advisory Council. We're also joined today by Yumin Tan, who is a psychotherapist here in Rhode Island and a life coach based in Providence. She specializes in treating anxiety, depression, trauma, cultural and identity challenges, relationship issues, career choices, and life transition. She's passionate about helping individuals find strength, build identity, and transform life challenges into opportunities for growth and healing. Thank you so much for joining us today. I'll also mention that we are joined by Mental Health Association interns Carlie Dureski and Bailee Peralto, who will moderate today's discussion. And now I turn it over to you. Thanks, Carlie and Bailee.
Thank you so much, Lori, and we're really excited for the panel today. So to start off, I think we kind of wanted to discuss or open the conversation with the experience of mental health from the consumer side. So starting out pretty broadly here, we were hoping to discuss some examples of how one's culture or race can influence one's mental health. We can just like popcorn in here if anyone wants to start out.
So I guess I can start. So I think when I was thinking about this question and I thought about double consciousness. And so having to be aware of myself and having to be aware of others and what that means as, a Latina. So I really started to think about what that means for our clients. And then the multi-generational trauma. So immigration laws, redlining, all of those things that go along with it. So those are the two examples that I felt were valuable to give.
I can go next. So when I think about that, because like I have a big portion of my clients are Asian American, so they come to me for anxiety, depressions, or various issues. I noticed that has a lot to do with certain stereotype in them, right? Like for instance, we hear about model minority in Asian American, right? The pressures to live up with that stereotype really causing a lot of anxiety and depression. And yet it's a positive stereotype, right? So it's even harder, right? It's like hidden, and it's really hard for them to, ask for help. Again, because you are supposed to figure everything on your own. You are the model minority. So I'm just thinking on that, stereotyping in a systematic way can impact someone's mental health.
Yeah. And I thought of a few different examples. One of the things, more broadly speaking, I think is just the stigma of mental illness in culture, from your cultural background. And that's understanding kind of how, I think of, I'm a therapist, and I often talk about the first time I did an intake with a patient, and we do a year of like getting ready and interviewing our colleagues or our other students. But then like my first real patient comes in and I'd start doing the intake and they just start telling me all this stuff. And I was like, hold on, you don't know me like that. Like culturally, I have to know your grandmother and I need to know like, where you grew up. But this person was like, I need to tell you, you're a therapist, like that is. And so understand, so kind of the understanding of how you interact in a therapy session. So that's kind of, but just kind of how And so that's from my aspect, coming in culture as a different culture of that person. But broadly, in terms of how your culture can impact how you interact with within the mental health system, but also the idea of stigma in terms of like your self-stigma, what you perceive, like what will people think about me if I talk about having a mental illness, but then the public stigma of the true perception that people have, right? So some people don't reach out for help because of what they think about dealing with mental illness versus what other people are going to say. And it's like dealing with both of those, the self, as Yumin actually was speaking about, it sounds like, and then kind of publicly how we view it. And then resources, I think, that are available. If a person is used to a certain type or certain type of interaction, those are not available, I think, as broadly for people from maybe different cultures. And then the support within the communities. So if you're, like I said, if your mother and father and aunts and uncles don't think it's a good idea, you probably aren't going to do it in some cultures. And so understanding that layer, I think, is something that we as a mental health community need to take into account as well.
And building off what Yumin mentioned, how you've noticed the increased stereotypes or pressures from the stereotypes leading to anxiety or increased depression. In your clinical experience, and this can go to all the panelists, are there any specific mental illnesses that you guys have noticed have been experienced disproportionately by individuals of a certain race and culture or culture?
I don't know that they've been experienced any more or less, but I will say the data show that for African Americans, they are diagnosed at a higher rate of schizophrenia versus bipolar disorder. We see that as a significant disparity in that, and not in terms of symptoms being taken, the very same symptoms and still being portrayed as, and schizophrenia is treated very differently than bipolar. And so that's one that popped into the front of my head in terms of how that, but I see that also in patients, like if we talk about symptomatology, I've had patients who said, I know someone is following me, right? And if you're a person who doesn't understand racial trauma and the fact that people do follow people in stores and, all around, you might classify that as paranoid behavior and thus diagnose inappropriately. So that's how I've seen it, just in that.
So for me, when I was working, doing a lot of one-on-one therapy, direct work, a lot of my Latina clients would come with me with personality disorders. And that has to do with, after really assessing and doing the work, many times it was not. And so as a provider, I had to do a lot of advocacy because when in the healthcare system, sometimes it's the doctor that provides the diagnosis, even though I'm a licensed mental health clinician. So it was making sure having that communication with the team because I was seeing something culturally different. And, Latinas are, there's all these lovely stereotypes about being hot-headed, emotional, and all these other things. And so when explaining that in English, when your emotional language is in Spanish, it's very hard to explain your emotions in English. It's hard enough for a culture that doesn't necessarily always understand mental health and it's stigmatized. So I think it's one of the things that I noticed most with my Latina clients.
Yumin, I think you're muted.
Thank you. So for me, I think symptom-wise for Asian American, they tend to manifest with a lot of body pain, like a lot of somatic experience, because again, like mental health, still there's a lot of stigmas around mental health within Asian Americans. So a lot of times they will self-diagnose, or maybe because they tend to repress their feelings. So a lot of symptoms, again, will manifest physically. So they notice that they will have headache. They notice that, literally there are terms in, Chinese let's say called 肾亏, like it's a diagnosis for like you have kidney problem, but data shows that stems from anxiety. So again, that's what I'm seeing, within the Asian American community.
We had a question come in from our audience, and it relates to what we're talking about. So I'll just read it for our panelists. I think the question was inspired by something Dr. Jennings noted. Are there any assessments that specifically look at race and trauma to help determine actual experiences rather than, quote, paranoid thinking?
Yes, there is one that's I was looking at. I was going to try and pull it up and put it in the chat. So apologize if I'm not making eye contact, but it is the clinical assessment of racial trauma, and it looks at assessing, looking at PTSD symptoms, and underneath that there's a additional. It's called the Yukon Racial Ethnic Stress and Trauma Survey, and it comes in Spanish and English. It's called the Unrests. So UN and then RESTS. And that's a specific measure. And that's one of the few that specifically, I mean, I think that's been one of the tricky things, right? Because that's been one of the issues that I've had. It's just risen to the top for me lately in understanding like how we work with people. I talk a lot about when I'm working, doing initial assessments, I ask about trauma, sexual trauma. Have you been in a car accident? But I've never asked not one African-American person if they've experienced being stopped by the police. That's a different, and not that any other, but that's something like, just given kind of what's been going on in this last year, I'm like, oh my goodness, like, and to hear people's stories when they talk about that, heart racing, just a change in who they are. And so we don't ask about that routinely. Not that asking about sexual trauma doesn't bring about the same thing, but I would not think to ask that about sexual trauma in any time, but I've not once asked about, a person's racial trauma, which they are much more likely to experience given the current environment. So thank you for that question.
Thanks. And if you have the name of the study.
Yeah, I'm going to pull it up. Yep.
Oh, thanks so much.
Sorry, I'll put it in the chat. I just didn't want to make it look like I wasn't paying attention, but I am. I'm always. Okay.
I see we have an audience member with their hand raised. Feel free. I just should have permitted talking for you. So if you have a question, feel free to ask it.
It's Annette. Can you hear me?
Yep.
Hi, Annette.
Hi, how you doing? This is Annette from NAMI, on a peer program coordinator. And I just wanted to add that, with the African American and some other minorities, that they're brought up to not even talk about mental illness. That's how bad the stigma is. And it roots from way back in the day. It's an embarrassment, to the family, and it cannot be spoken about. And that's one of the barriers of why Black people don't come forward, with their problems, to get some help. And some of them, even myself, was not even aware that I was living and mentally challenged. And there's one other thing that I wanted to mention. Oh boy, it just slipped my tongue. It just slipped my mind. Oh, I wanted to mention that at NAMI we give a peer-to-peer recovery education program, and it's an excellent 8-week course, 2 hours once a week. And it talks about everything that you ever wanted to know about mental illness, but you were afraid to ask. Okay, just put it that way. Put it in a nutshell. It's a very good course. And I've been teaching this course since 2015. And I am finding that the majority of African Americans that participate in this course are Black men, really, and a very, very, very few brown and Black female. And I'm just getting the opinion that maybe the cycle will soon be broken because you know how men are supposed to be the head of the household, that maybe that will begin to change things, and you know the men can educate the first starting with their family and then spread it on and stuff. I'm just hoping that there's a change because I do the demographics for that, and I've been doing it since 2015, and it's very poor with the Black woman that attend this educational course.
Annette, I had a question. From whence do these men come? Are there a certain, like, are they from the community or are they from other programs? Like,
there are a lot of referrals from their PSN and from Butler Hospital and from other psych places, you know, where people go for support or where people go when they're having a problem and they're hospitalized, probably the Jane Brown building. But they're referred to also by their therapist
okay.
to come over to take the course. And when we do screen them, and one of the questions that we do ask them is, you wouldn't mind letting your psychiatrist or your therapist know that you are, you know, taking this course, because that's good for them to know that, you know, they're trying to learn more and more about themselves and this sickness, because that's what it is.
Thank you.
Thanks, Annette. Thank you for sharing that program exists at NAMI. We love NAMI. We refer people to you all the time, and we really appreciate your sharing that. You're doing great work.
Thank you very much.
Of course, of course. Carlie and Bailee, I turn it over to you.
Sure, yeah. Thank you all for joining us on the panel today, and thank you, Annette, again for sharing. Something that I researched quite extensively during my senior project at Brown, which I completed alongside Lori at MHARI, is barriers to accessing mental health for people of color. So according to a report by the Substance Abuse and Mental Health Services Administration, the percentage of people with mental illness who are in treatment varies by race. Specifically, about 50% of white folks with any mental illness receive treatment, while this number drops to about 33% for Black and Hispanic folks. So my question is, what factors do you believe underlie this discrepancy? For example, do different races face different structural barriers in accessing treatment?
I can start. So one of the things that I thought about when I was thinking, when I was reading the question, I was thinking about the literal barriers. So when I think about the literal barriers, I think about, you know, lack of public health insurance, depending on what the insurance covers when it ends. If someone's doing an intensive outpatient program, you know, your insurance won't cover for more than 2 weeks sometimes. Or if they need substance abuse treatment, you know, the amount of days that you get, you might not have gotten to a strong point in order to be able to be out in the community. So all of those things are a barrier. And then public transportation. So our infrastructure, it's right now, I think with telehealth, we've seen more people willing or able to keep because we're really working around some of their life, and people can go on a walk and take a Zoom call and they're in their neighborhood, or they're watching their kids from afar in a playground while they're doing their therapy call, which is very different from what we've allowed people to think about when they think about healthcare. So those are the two main things that I've seen over the years. And now having telehealth, I'm just like, oh, this is amazing because it really creates access. And those that want to have in-person sessions can still have them and have the means, but there are others that do not. And we really need to continue to have those conversations.
I mean, I agree with all the things Sandra just say, and that's something that I've been thinking about as well. But I also thinking about the value within the community also contribute to that. I just speaking from, you know, an Asian American standpoint, I think just the fact that with the model minority stereotype and also plus the value within the system, like, you know, really not encourage, again, people to reach out for mental health or take mental health seriously, right? Like respect your elders, like elderly, you know, honor your family, right? All those things won't really allow you to talk back about your family, because in therapy, a lot of times it's about family, right? So, so with all that, it really not encouraged. So with that say, because of that, there's not a lot of Asian American therapists out there. You know, their data shows only 7 out of 10,000. You know, like 7 people literally out of 10,000. So I just want to also say that with resource wise, there's not a lot out there.
I was actually going to piggyback on that, Yumin, and Sandra, both of you. I think all of those things, and saying about lack of representation, right? We say it all the time, representation matters, but it really does. And I think, you know, like I said, when someone walks into a setting and sees no one that looks like them, not even if it's you know, I'm not even saying the therapist anymore. I used to say that, like, you know, let's try and, but just no one who looks like them, or any indication that there's anybody in the building that might have a different perspective on things, right? So I'm, you know, not even, but I do think having therapists and providers, or providers period, be it the therapist or a peer counselor or whoever is in service, making sure that that representation is there, and being more mindful of that as you build a practice, or as you know, I'm always trying to find people I can refer out to. Language, one of the issues for me, I don't speak Spanish, and I get patients referred to me who speak Spanish. And I will say to them, I think we're going to need to take more time, because if we have an interpreter, I want to make sure that relationship is good. And oftentimes speaking through an interpreter to say something is very different than speaking one-on-one. I know that just in terms of my interactions with people and so we need to understand that. So, oh, I have an interpreter, great. Well, that's fine, but are you allowing more time? Are you making sure the patient I had one patient share with me, you know, who spoke English, but in the setting needed an interpreter. And at the end of the session, she's like, this interpreter was good. They actually said what I wanted them to say. And like to recognize that that's something that could happen in a session, I was just like, oh, 1, I need to learn Spanish, but 2, I need to make sure my relationship with the interpreters are clear. And I think that those types of things are important. So just simply having them, but also building good relationships and making sure that they're comfortable, because sometimes they're in situations where they may not feel comfortable. Maybe it's someone they know from the community, or just a topic that they, you know, so let's find more than one, you know, not let it be the only one person doing the interpreter is something that I've saw challenging.
So I would like to add to that, if I may. So one of the things that we need to be careful with is that our communities talk, and so, you know, Dr. Jennings doing what she did with with her patients really shows that she cares and she's involved, even though she doesn't know the language. So they're more likely to then refer and say, you know what, mental health therapy is amazing.
Sandra, I think you're frozen. I think we've lost you. Maybe it would help to log off and then come back, if you can hear me. So sorry. Well, perhaps we should move on to our next topic, and then when Sandra joins us again, hopefully she can complete her thought.
That sounds good. It also might help, Sandra, if you turn your video off. Sometimes connection can be better with just the audio. But yes, in the meantime, we do have some questions in the chat, mostly related to the importance of a diverse provider pool. So I think we can address that. So we have 2 questions that I can see, or maybe 3 questions that I can now see. But the first one is, how can we as white clinicians and behavioral health staff create a more welcoming environment for our clients of color to feel more comfortable opening up about their experience?
Well, I can speak a little to that in terms of some of the things I talk with people about is one, educating yourself about some of the, not some, but the pressing issues in the community. So again, understanding it's not for your patient to educate you, that you are, you know, you're there as a source of a resource for them. And so educating yourself on what's going on in the community, number one. And it doesn't have to be, you know, the entire community, but your community and how the people of color are being impacted in your community, just having that. I also say, make sure you're engaged in activities outside of the practice so that you can see how people live and what they do. People are very welcoming here. So those are things outside. Within the practice, making sure that there are, like I said, multi-language signs in multi-languages so people can see, okay, this is a place that respects the fact that everybody may not speak the same language. And you may not have someone there, but have like a, you know, I know it's not the best, but the Google Access line for language interpreters. But if you have a person, but having your signs, like I said, in multiple languages, pictures of people, you know, not all this, like magazines, which I don't think we do that anymore because of COVID. But if you do have magazines, like they, you know, not all of the same person on the cover of every magazine. It's like, okay. And I don't even, like I said, I don't even know which ones are out anymore, but those kinds of things. And then respecting, and that's like, there's like a whole checklist that you can do. But like the multicultural intake checklist kind of speaks to some of the things that you can do as you're talking with people, but just in terms of in your therapy and acknowledging, you know, a person's background and their culture and asking about it, right? Rather than, I understand people want to highlight the ways that we're the same, but also asking about it so they feel comfortable sharing with you. And once they, you know, they have the right to say, I don't know how to talk about that, but like just asking, you know, if in any way, you know, tell me about your culture. Tell me, you know, tell me. And some people, I've even had people, I say that to most everybody, tell me about your culture, and have people who are from certain backgrounds are like, I have no culture. I'm like, I'm sorry. That's not, we all have a culture, but if you don't feel comfortable talking about it, that's fine. And so I think being open about it is some of the things I've seen that be helpful for people.
Sorry, I dropped away, you guys. I'm back.
Welcome back, Sandra. Just to quickly catch you up to speed, we're talking about a question in the Q&A, mainly how can we as white clinicians and behavioral health staff create a more welcoming environment for our clients of color to feel more comfortable opening up about their experiences?
So one of the things that I would say is really allowing our clients sometimes to know how we're understanding diversity. Right. So how are we practicing anti-racist practices? And so some of the things that Dr. Jennings was just speaking about are aligned with those, like our gift stores. Are they, you know, in our hospitals, are they selling culturally aware and appropriate items, you know? So I think it's all of those things, but then also making sure that it's not just about us as clinicians or providers, it's also making sure that our front desk staff, our, you know, those that are in our facilities departments have understanding as well, because offhanded conversations can happen in hallways, and those offhanded conversations, when we're not training everybody in the system, can then cause problems and cause and really hurt people. And so we really just need to be aware of all of our points, because that is the environment the client's walking into, is that whole building. Is that safe?
I want to add one more point. It's just be curious, right? If we don't know, so we just ask question, and not assuming that we know. I think clients will appreciate that. Even you don't know everything about them, but just be curious, be open. Yeah.
And I think, okay, I have 18 things, but in terms of like, if you're thinking about things that you're doing forward facing to the community, like reaching out and trying to find other faces. A lot of times the reason why we, have people like us around us because we're comfortable and, okay, and maybe they all look like us. And that doesn't necessarily communicate to others that they are welcome. So just, making a point to, if you have events or if you're going to be doing talks, like reaching across maybe one new person, inviting them to be a part of the panel or inviting them to provide resources or their card or something like that, that you might not do, when you're referring out, like making sure you have a broad range of people, not in terms of services that they can provide, and always kind of seeking that, and that will keep you kind of in the loop of what's in terms of what's changing, what's not, and what people are open to, I think, as well.
Moving on to another question asked in the chat this time. So the question is, how do you recommend making the counseling field have more diverse providers? I am often the only POC provider at my facility, and so often work with the clients that are POC.
So that's a big workforce problem that we have in our state and all over our country. So I think, one of the things that I often talk about is, and Dr. Jennings is smiling because she's heard me talk about this, is that we need to educate our children, because our children, unless our children start becoming comfortable with mental health language and what mental health is, then they will not choose this as a profession. And for me, I was deterred from going into this profession by my family because they didn't see it as something that was real or something that was needed, because our culture my Latina Mexican background family didn't speak of this. And I now talk about how many of my family members have been in different forms of therapy because they saw it works and it helps. And so that's why when I was speaking earlier, it's one provider makes a change. It makes a difference on whether other people will be coming forward. And so I think now we've had, kudos to you as someone that is providing treatment, and that there are more POC, BIPOC and immigrant clients coming to the door, because that's why more people are coming forward, because they feel comfort. But we really need to help and support and mentor. So if you're in a position of mentoring, I say, an undergraduate student, they don't know how to navigate. Sometimes they're first generation professionals, and remembering that about ourselves so we can then help them walk through the pathway and feel validated about going into this field. So a lot of support. It takes a village in order to have clinicians that are of diverse backgrounds, because it took a village to build me.
And I think as a person of color who provides therapy, it's, I guess I did a lot of my work originally in the research arena, and I was hesitant to start providing services because I knew that there were a lot of people in the community that were of need. And I said to myself, oh, I can't help all these people, right? And that's a, burden one. Why would I be the only person that could help people? But in my mind, that's what you do. If a person needs help, you need to be there to help them. And if you can't help them all, oh my gosh, it's like feeding them all. Like in my family, you bring enough for everybody. And so learning how to, one, reach out and do things like this, encourage people to become part of the provider network, recognizing that the types of services that can be provided, like we've had someone talk about the peer-to-peer, different types of therapists, different types of psychologists, there's inpatient, outpatient programs, all these things are available. So it's not just me that will be providing it. And I often make a point to educate the people around me. Again, that's why I enjoy being part of things like this, is because, I can't be the only one. And so people are like, oh, can you see this person there of a certain background? I'm like, hey, I have an idea. How about we all learn how to be open and curious and provide meet people where they are and understand their culture, because that's really all I'm doing. It's not like I'm me personally, I'm this amazing, I'm not. it's just because I'm listening in a way that's non-threatening. I'm not considering their symptoms as paranoid, you know, those kinds of things. It's like, okay, those are things I'm doing. How about we all kind of work on that? And sometimes it is the identification that opens things up, but my clinical skills have to work to help them. And there's certain things that I think we all have as therapists, but people need to be able to see that initially.
Yeah, so I think we are talking about cultivate the culture, cultivate the environment here, right? Like people come together and create, like, let's say an event like this, or, you know, just support each other and getting to know, you know, who is in the community, right? Referral and all that. But I will say, yes, it probably will take a few generations to catch up. So I think patient, really, that's what I have in my mind.
I think to add to everything that's been said is really, I think we just, you know, I make a call out to my, you know, Caucasian and white peers and saying that it's exhausting for those that have diverse background, BIPOC, immigrant therapists. And so we need help, and it's important, you know, for us to work all together in order to be able to understand how to connect with the community. And it's super valuable because it's hard being the only one. And, you know, to the, you know, the audience member that asked this question, it's really, really difficult because there are things that I've had to learn differently because I don't just service Latinos. So I've had to be curious. You know, I didn't really know about Afro-Latino communities and cultures in you know, in Puerto Rico or Dominican Republic, but I was curious enough to learn because it was important for our clinical relationship and for the clinician I was becoming. So that self-awareness and understanding that humanistic approach is important. And so I challenge you, I urge you to, you know, to be the support.
So our next question from the Q&A kind of circles back to the discussion about language and how different languages may have different words to describe mental illness symptoms. So the question is, as someone who speaks a second language, how important is it to know the specific psychological terms in the language alongside conversational language?
So I've found it valuable in certain sense to continue my curiosity because there's not enough research for the Latino communities and cultures in English. So I've had to read psych articles in Spanish from other countries. What I've learned is that because it's new to, at least, you know, for the communities, the Latino communities that I've provided treatment to, using some of that terminology isn't extremely helpful because there's no knowledge of it. So, you know, in certain countries of origins, it's only the affluent people that can have, you know, treatment, or, you know, that mental health is spoken in. And a lot of the communities that are here in the United States are immigrant communities that are, you know, middle class, or, you know, have just barely made it here. And so using that kind of language is not going to necessarily create the clinical rapport for people to disclose information. So I do an assessment. Every individual is different. And there are some of my individuals that have asked for that, and we go down that path together. And then there are some that really I use terminology that can be that my client can understand, and that they're able to take away the message of what it is that they're wanting from treatment. So I guess I you know, to answer your question, it is important for us to learn, but not necessarily as important to have it in the session, depending on your client.
Yeah, I agree with Sandra, because I think even myself, it could be a challenge. Let's say I learned something in English at my training, right? So all those questions are created in English. So when I have a client speaks Mandarin, Chinese Mandarin, I often felt like if I translate it directly, actually it does not make sense to them at all. So literally, I need to say something that can resonate in that culture, in that sense with them. So with that say, I will say, right, it sometimes it doesn't make sense to stick with the exact term because it's a translation. So more importantly, it's you building your relationship with your client, and you get a sense, really trust your instinct and your relationship at the time, and speak the language that the client can understand. I think that's the most important thing.
So we see another question in the Q&A. We do have one or two questions, like prepared questions we're hoping to get through, but we will definitely circle back to that if we have time. And if the panelists are willing, we can also leave emails in the chat if we'd like to continue the conversation outside of this panel. So the next question we want to talk about is just generally the importance for mental health care providers to consider their clients' culture and race when working with them in therapy. So no, we've talked about this on a general level, but I was hoping that we could maybe discuss specific examples of the importance of considering a client's culture or race. For example, are there certain treatment approaches that may be more effective for individuals within a certain culture or race in comparison to others?
I was just, so broadly, I was going to say there's not one, we try to step away from this. Okay, if you see an Asian American, this is how you need to look and talk to them, right? And that is actually how I was trained. Like 15, 20 years ago, there was like a list of things you don't do and things you do with certain types of patients. And while it was based on research, I think it was because we didn't have a lot of interaction with people from different cultures. Now there's a lot of heterogeneity in even different populations, and we need to acknowledge that. So that's kind of my broad thing. But I think in some of the literature that I look at in terms of when I'm like, I think of people from, especially being here in Rhode Island, that we have people from all over the world come in. So I try to make a point to look at the literature for a person from a different, I have a person from India and a certain part of India, right? Understanding where they came from and understanding maybe some of the family issues that might come up in the context of therapy, right? And so understanding the impact of family on intervention, I think, in terms of how people kinship bonds and what they mean versus being maybe in a more individualistic society. So that's something, to take into account. I think of level of acculturation. So a person's identification, again, with different acculturation and assimilation within the context of doing an intervention is important. How long they've been in this country and or another country, language that they speak and different things like that. And then one of the things that I think about in dealing with people from maybe a different cultural background is not necessarily some of the things that we see that work better are coming from a strengths perspective. I think a lot of time people experience things where, it's pointed out each deficit and why they need to do better. And I think as we can point out to people, especially if we're trying to reinforce their self-efficacy and things like that, highlighting the strengths. I often highlight to people like, it's amazing, 3 languages. I am still trying to manage 1. And clearly I struggle with that, right? But here you sit. So let's use that as you continue on to work through this trauma or whatever. And I think doing that is something that I think people from a different culture, like I call it their superpower. I'm like, you already have this down, And so coming from a strengths perspective, I think is something that we see that works well.
So everything that Dr. Jennings just said, I've done. Empowerment is very key. Our communities have been oppressed, and so empowering is extremely important because there's a lot of self-doubt, but it's also understanding for them to understand their story. So sometimes I will do narrative therapy because our oral history is extremely important. A lot of our history isn't written down for our diverse clients. And no one sat down to ask them their story sometimes. And so I do use that narrative piece and the oral history because it's important for them to hear what they've already gone through and the generations of things that have happened in their lives. So that empowerment piece is extreme. It's key. I think, it's an eclectic approach that I've always used, wherever the client is wherever I meet them. And that's more of a humanistic approach for me because I know that my clients have the power to be wherever they want to be because they've already got there to me. And that's really hard. And I think that in itself, the client sitting there in front of me, whatever race, culture, it's really hard to admit that you need support and help. Even if you come from a family that speaks about mental health. And so I think it's always extremely valuable to remind them of that.
So I agree with everything both you say. For me, I noticed that the clients that come to me, I need to do a lot of psychoeducation. The reasons is, again, for that community, it seems like they really, suppress a lot of their feelings. If I start with their feelings, basically I get probably not a lot out of them, right? Sometimes, it's hard for them to actually articulate how they feel. So I think really explaining to them, right? Let's say how trauma work and how that changed the brain and how that changed their body. And it's easier for them to buy into, doing therapy and then continue our conversation in session. So another thing is, I do a lot of somatic approach, again, because I'm feeling a lot of the symptom really manifest with their body. And I just feel like if I can help them to connect with their body and start with that, it will be easier for them to start therapy.
Thank you all. I think we'll transition to probably one more question from the Q&A. So Denise asked, a lot of what the panelists have spoken about sounds like the practice of cultural humility. Can any of you speak towards cultural humility versus cultural competence, specifically the shift from competence to humility?
Well, I'll just speak in terms of talking about this idea of competence, the idea that you'll ever have it, right? And I think as a person who's been in school almost all my life, I think it's great. I'm like, oh, one day I will know everything. And then as I've learned from being in school in my life is that you never know everything. And so I think that's that shift to humility, right? And I often talk with my colleagues because they say, well, I don't want to say the wrong thing. And if you come from a place of humility, you are, as Yumin was talking about, remaining curious. And you're never going to know it all. So I think understanding that's that shift. Like competence, we have a checklist, right? I'm at 90% competent, right? But if we look at cultural humility, we're always learning, we're always open, and if you do something in that vein, you stay open versus, oh, I got it. I took my multicultural class, I'm good. And that's what I think was happening.
I concur. That was exactly, that's the moment. I was just like the super nerd that wanted to learn it all. And I thought that someday I was going to know it all. And then I'm like, wait a minute, that's not the purpose. Things just kept on getting thrown at me and I kept on wanting to learn more and I stayed curious. And even when I have had mishaps, because in Spanish, certain words are swear words in other communities. And so I will say something and they're like, whoa. And I'm like, ooh, I'm sorry. I speak Mexican Spanish and that's what I start off with, because then they see that I have a level of awareness and that I'm saying, we're going to work together on this rather than I'm the one that knows everything. And so I think that's the other thing that we've done a lot within the mental health field, is that sometimes we are the professional and this is our client, but we also learn with our clients, because I've learned a lot about culture and the way people live through my clients' resources. Sometimes they have the most resources. And so it's extremely valuable, again, to give that empowerment back.
Yeah, I mean, human being is so complex, right? And every individual's history is so different. So again, I just have to say that I'm still learning. I'm learning every day, and I probably will. Yeah, there's no end for that.
Well, thank you to all of the panelists so much for joining us today. If everybody is willing, we would love for you to drop maybe your emails in the chat and let everyone know that if they would like to, we can continue this conversation beyond the 1 hour time limit of this panel. So thank you all so much. And with that, I'll pass it back to Lori.
Thanks, Carlie and Bailee, and thank you, Dr. Jennings and Yumin and Sandra for joining us today. We really appreciate your sharing your experiences and offering guidance and encouragement. And we really appreciate your opening yourselves up to these questions and answering so openly. And thank you for putting your email addresses in the chat box. If we didn't have time to get to your question today, the panelists who participated have added or are adding their email addresses, so you can reach out to them directly. And stay tuned, because we'll have more May is Mental Health Month workshops throughout the month of May. Again, thank you to our sponsors, Butler Hospital and Rhode Island College. We really appreciate your support. We appreciate everything all of you are doing. Thank you to our audience for joining us today, and please subscribe to our newsletter and our Facebook page so that you will stay in the know with Mental Health Association happenings in the future. Thank you all. Have a great day, stay well, and take care of yourselves and take care of each other.